and let me introduce Associate Professor Tom Cox, who's the lab head of Matrix and Metastasis at the Garvan Institute of Medical Research, and also Associate Professor at the School of Clinical Medicine at the University of New South Wales. And he, like the presenters before, was involved in directing the preclinical work of PXS-5505 in the pancreatic cancer models.
Great. Well, thank you very much for the introduction, and also thank you for the opportunity to come and talk to you today about some of the preclinical work that we've been doing with regard to the Lysol oxidases in the pancreatic cancer space. Now, just by way of background, I'm at the Garvan Institute of Medical Research here in Sydney, just down the road actually from the Pharmaxis headquarters. And so the Garvan was founded in 1963. It currently encompasses around 600 researchers that focus on around about 50 diseases. And we collaborate internationally with research partners all over the globe. Most of our work falls into four major areas of research, being cellular science, genomic science, translational science, which is what I'll talk to do today, as well as data science. Now, Garvan is actually quite unique in one sense in that we are situated within the St Vincents Hospital precinct here in Darlinghurst. And this means that we essentially, as scientists and laboratory heads, rub shoulders with clinicians on a daily basis. And this is particularly the case for my laboratory, which is based within the Kinghorn Cancer Centre here at Garvan. And what this actually allows us to do through the Kinghorn, for example, which has dedicated phase 1, 2, and 3 clinical trials unit, is really take ideas through from that discovery and development phase and into clinical trials to begin moving them forward into practice. So we've already had a little bit of an introduction about the extracellular matrix, so I won't bore you with this too much. But essentially, we know that the matrix is the stuff outside of the cells, and it's responsible really for allowing your cells in your body to form tissues and those tissues to form organisms. Now, I'm just showing you, and I hope you can see on the right-hand side, a video that's playing. And what this is going to use it as an example to show the interplay between cells and matrix. And so you should be able to see purple strands or fibers. These are collagen fibers, collagen 1 in particular. And these have been imaged here actually within the lab at the Garvan. And so this is live cell imaging, and the green blobs you can actually see. These are neutrophils in this example. And what you should be able to see is that these are moving along those fibers. The collagen fibers are sort of giving them directions about where they can move and where they can't. And so this idea that your extracellular matrix of tissues regulates and controls cell behavior. But if you look and follow some of these closely, you'll see that they are also, these green cells are also capable of moving those fibers around, degrading them, changing their position. And so this brings in this idea that we know as dynamic reciprocity, that cells are able to change their microenvironment, but as that microenvironment changes, the feedback onto cells also influences that behavior. And this is incredibly important when we come to think about solid tumors, and in particular, solid tumors where we see fibrotic and desmoplastic responses. So we know essentially that the extracellular matrix is incredibly important in normal tissue function. In fact, it's what allows all of your organs to carry out their normal function, but it's also very carefully controlled. And just on the right-hand side are some of the different facets of the extracellular matrix that come together to impart information to the cells in order to regulate that behavior. Now, it was already mentioned by Paul in his previous talk, is that a lot of solid tumors have a significant remodeling or change of their extracellular matrix. Essentially, normal tissue matrix in something like the pancreas or the liver and even in the bone marrow is significantly changed. And this is why it is incredibly important that we now think about the environmental tumor microenvironment in addition to the tumor cells. And so we're moving away from this idea of a tumor cell-centric approach to treating cancer. Now, this is a talk about pancreatic cancer. I'm just going to very briefly bring some of you up to speed who might not be aware. In Australia, it's around about 3,000. I think it's slightly higher than this now for 2021 numbers, like 3,400 deaths annually. This actually equates to about 450,000 deaths worldwide. The probability of survival is about 9% at 5 years, making this one of the worst prognoses in solid tumors. For those that are surgically resectable, which is about 15 to 20%, this may offer a curative approach. However, for most patients, chemotherapy is usually the only option. And as I've already mentioned, the highly fibrotic nature of pancreatic cancers is really something that we're grappling with in order to understand why many of these patients don't respond. So we've already heard about how pancreatic and liver cancers are among some of the worst and the highest cancer-related deaths. Just to put this into perspective, the median survival for untreated pancreatic cancer patients that cannot undergo surgery is about 3 to 4 months. With the best possible treatments that we currently have available to us, we can extend this to about 6 to 8 months. And worse still is that this has barely improved for the last 2 to 3 decades. And so we've got this huge problem. And so any new treatment that has the potential to improve outcome in this disease is really seen as a breakthrough. Now, to give you a bit of a visual representation of what we mean, Gabby already showed nicely how the bone marrow is changed and you get this fibrotic nature. This is very similar to what we see in pancreatic cancer. So on the left, you'll see this sort of pinky red image. This is a slice of the pancreas from one of our models, and outlined in this circle is the a growing pancreatic ductal adenocarcinoma. Now, this red that's stained is actually staining for collagens, and using a clever trick using polarized light microscopy, what we can do is we can visualize the fibrillar collagens, and this is what's shown here in this yellow, greeny, orange. And so what you'll be able to see is that we get this very fibrotic high level of desmoplasia around the outside of the tumor that also penetrates into the core of the tumor. And it's this buildup of this scar-like tissue, if we can call it, that is really what actually leads to decreases in efficacy of standard of care therapy. But it doesn't just affect the response with therapy. We also see that it can make cancers more aggressive, and it can also act as a physical barrier to delivery of adjuvant therapies, but also to immune cells. And this may explain why many pancreatic cancer patients respond very poorly to immunotherapies. Another thing which I just mentioned that I won't talk about is that these fibers may also act as highways for your cancer cells to move and spread around the body. Now, this is a bit of a busy slide, but what I want to take away from this is that this sort of prominent pathological characteristic that is pancreatic cancer fibrosis is really as a result of secretion of high levels of fibrillar matrix proteins, and in particular collagens. And this is typically carried out by a cell type known as cancer-associated fibroblasts, which are a non-cancer-like cell typically recruited from within the normal tissue as tumors grow. Now, this is activated by many different mechanisms. Some of the growth factors I've just listed here that may be familiar to some of you. But the important thing to remember is that once this fibrotic response is activated and we begin to see the secretion of large amounts of matrix into that tumor space, just as I showed in one of the first slides, all of those different facets of that matrix feed back onto all of the cells that are present. And so what happens here is, as actually Gabby mentioned, is a sort of a vicious cycle where we see increasing fibrosis that's feeding back onto cancer cells, making cancer more aggressive, leading to more fibrosis. And we get this, as we call it, dynamic reciprocity, or a vicious cycle. And therefore, our hypothesis was that, well, if we can target that deposition of that matrix, we can block this fibrotic response. Can we break that cycle, and can we then improve the efficacy of our already approved standard of care therapies? So we've already heard about the Lysol oxidase family, so I won't have to introduce this, other than to say that they are fundamental to the genesis of collagen fibers, both in normal tissues, but also in tumors. And that the opportunity with 5505 as a pan-family inhibitor that is highly specific and well tolerated, when this came about, we jumped at the opportunity to look at that within our pancreatic cancer models. Now, a little bit of background here. If we look at the Lysol oxidase family members, all 5 of them are actually associated with poor survival in pancreatic ductal adenocarcinoma. And so this is individually. And so this really sort of supports the idea that, well, we should probably be thinking about targeting the whole family. And this is likely because there is a little bit of overlap and redundancy between the activities of these 5 family members. However, if we begin to create slightly more sophisticated analysis and take all of the expression of all of those 5 family members to create combined signature scores, and this has been carried out in 2 patient cohorts, the Cancer Genome Atlas and one which is part of the Australian Pancreatic Cancer Genome Initiative, then we can see that the light blue lines, which are a low family score, indicating low expression of the 5 family members, is associated with an approximately 2-fold increase in patient median survival. And so this again reinforces this idea that by targeting the entire family, then we might be able to improve outcome. So we used a number of models. I'll just introduce 2 of them quickly. The first is our genetically engineered mouse model of pancreatic cancer, also affectionately known as the KPC. This is because it carries 2 major mutations found in pancreatic ductal adenocarcinoma, one being a KRAS mutation and one being a P53 mutation. And the other is that we use our patient-derived xenografts. So these are samples of patient tumor that are undergoing surgery that are then implanted into mice. And these have been collected as part of both the Australian Pancreatic Cancer Genome Initiative and also our recently launched Australian Pancreatic Cancer Matrix Atlas. Now, importantly, both of these models develop a high or a robust desmoplastic or fibrotic response. And so this is again that red, that picoseries red staining I showed you from before. And as the disease progresses through these last 4 images here, we can see an increase in the red, which is the presence of fibrosis. So in terms of our treatment and in discussions with the team at Pharmaxis, we decided to go with an approach, daily administration of the PXS-5505, and in combination with one of the current standard of care chemotherapies given to pancreatic cancer patients, gemcitabine. And so this was carried out in both our mouse genetically engineered models, but also our human patient derived xenograft models. And so it's PXS-5505 daily, chemotherapy given twice a week on a continuing cycle. And so just giving some early stage data, I will just caveat this by saying that this is actually under peer review at the journal Nature Cancer, and we're hoping that this will be out in the not too distant future. But an example here is, so this is a survival curve for our genetically engineered mouse model of cancer. And we can see that the typical median survival is around about 85 days. Adding our standard of care chemotherapy gemcitabine improves this by a small amount, similar to what we see within patients within the clinic. But importantly, and most excitingly, was that the addition of PXS-5505 to gemcitabine increases that median survival even further. And this is actually through, a decrease in the tumor desmoplasia or fibrosis within that primary tumor, and also decreased metastatic burden to the liver. So in the last 30 seconds or so, I'll just sum up by saying that we know that the deposition, this scar-like or fibrotic tissue that accompanies pancreatic cancer progression, plays a significant role in the poor outcome of patients. We know that the Lysol oxidases are crucial to deposition of this scar-like fibrotic tissue in pancreatic cancer, but in many other diseases as well. And so we strongly believe that therapies that can target this deposition, such as targeting the Lysol oxidases, offer a way to break, and to use Gabby, to break this vicious cycle, this feedback of the matrix onto cancer cells that's known to drive aggressiveness. And in doing so, we can augment the efficacy of our current standard of care therapies. And so we hope that our preclinical data in our animal and human models of pancreatic cancer support being able to take PXS5505 forward into some early stage phase 2 clinical trials. And so that I will thank everybody for their time, and I'm happy to take any questions.
Great. So again, I welcome back the panelists to launch into questioning Dr. Cox on what sounds like a pretty interesting and prospective potential therapy for a cancer that's obviously very poorly served in terms of standard of care treatments.
Well, if I can jump in with the first question. I've seen some suggestions that if you disrupt the fibrotic capsule too much in pancreatic cancer, that can actually accelerate disease progression. I just, if you start off just making a comment on that observation.
Yeah, absolutely. And you've hit on an incredibly important point. There have been a number of studies coming out over the last sort of 3 to 4 years. Many of them were actually focused at essentially ablating or removing almost all of that desmoplasia. Some of these have been through targeting the cell types, these cancer-associated fibroblasts that I mentioned, these sort of major producers of matrix. And what they had shown was that if you block the ability of tumors and the body as the host organ completely from being able to deposit extracellular matrix, then what you find is that you get a worse prognosis, that these tumors seem to grow faster. They also seem to spread earlier. The caveat was that they found that immune cells were more able to get into these tumors, and therefore these tumors might be more receptive to immunotherapy. But I think importantly, what it really highlights is that not all of the extracellular matrix is doing bad things. There is obviously, or at least my opinion would be, there are 2 elements to it. One is that you have a deposition of matrix as a result of the tumor-driven mechanisms activating programs that lay down a lot of matrix within that. The other is that you're likely to be having a, perhaps we could say a host response to that developing tumor, such that you have got cells at that periphery within the normal organ that are perhaps trying to encapsulate. And so rather than completely blocking the ability to lay down matrix, what we're thinking is a more nuanced approach such that we can block the cross-linking of the extracellular matrix being deposited within the tumor. And that's important, and this is linked back to a point that Paul made, is that cross-linking leads to a huge increases in stiffness. And we see this in a lot of fibrotic tissues. And that mechanoactivation or stiffness is known to be one of the major drivers that really trigger aggressiveness in that. So I think it's going to be this fine line between not getting rid of everything completely, but knowing what are those pro-tumorigenic modifications, those changes that we can block. And it really does look like this blocking of the cross-linking and stabilization of this dense fibrotic network might be something that would lead to beneficial outcomes rather than complete ablation that possibly leads to worse outcomes.
So in light of that, how would you see PXS 5505 being used in clinical studies in pancreatic cancer?
So this is an ongoing discussion, which we're having with the clinicians. Ideally, we would like to see this, it would always be used in combination with a standard of care chemotherapy, with the aim to augment that efficacy. I understand, getting these into first line can be very difficult, but what we do have evidence pointing towards is that you need to be giving it at the same time, or perhaps even earlier than chemotherapy, because what you want to do is to make sure you have inhibited your LOX activity such that when your chemotherapy comes in, you aren't, triggering fibrotic responses, which is something we do often see in response to chemotherapy. So definitely in combination with, and from a perhaps naive scientist's point of view, as early as possible, if possible.
Okay, thanks very much. I'll pass the baton.
Hi.
And maybe if I can jump in. Sorry. Go ahead, Bianca.
I'll be very quick. What is it in terms of the antifibrotic drugs that are being trialed in this? Look, I'm quite familiar with Amplia. Interesting to see that there's the Garvan, different groups working on different things. So maybe you combine it and do it all together. What is out there that people have tried to do this, to combine it? Because pancreatic cancer is so difficult. Everyone just tries it and doesn't really work. Immuno-oncology doesn't really work. The best we can get is sometimes stable disease. But what is it with fibrosis? Is there anything else that has shown something in the clinic?
Well, Paul sort of briefly mentioned the hyaluronic acid trials, and that actually perhaps speaks back to Dennis's point of trying to remove all of that fibrosis. There's not been a lot, antifibrotics or anti-stromal agents in the cancer setting are fairly new. This idea we've begun to accept that we don't just treat the cancer, the cells, we must also treat the microenvironment. You mentioned Amplia, obviously very well aware of the groups here at Garvan that are working on this. Realistically, I would say that there's two ways to targeting, or at least targeting that fibrotic nature and response. And if you remember back to one of the slides, I talked about this dynamic reciprocity, that you've got the deposition of excess amounts of matrix, lots of cross-linking, increases in stiffness. And what that does is that feeds back onto all of the cells present within the tumor. Now, this could be your cancer cells, it could be immune cells that have arrived in there, your cancer-associated fibroblasts. The environment affects every cell present. And so one way to look at it is to say, well, if you can stop the deposition of this, you can break that cycle that way. The other would be, and quite a valid approach, to step inside the cell again and say, well, we're going to let that fibrosis happen, but we're going to block a cell response to that change matrix. And so some of these molecules that target things such as the focal adhesion kinase, this is that nexus really between what happens inside the cell and that tumor microenvironment. So really you're coming at it from two different angles, which is, do we block the ability to create this highly fibrotic microenvironment, or do we target the cell's ability to sense and respond? The question then comes down to, does your target, your intracellular target, exist in all cells? And would all cells respond in the same way to that? Or do you take away the pro-tumorigenic cue in the microenvironment? And so I think there's definitely strengths to both. I love your idea that maybe you could combine them all into one, as this is, as you say, a horrible disease, and whatever we can do. But obviously that's going to require a large amount of funding. Study.
And do you, on the microenvironment, so the fibrosis also hinders essentially the microenvironment becoming more pro-inflammatory as well. So it is ultimately affects everything. that goes
absolutely.
on in that. Right, okay.
Yeah, so you often find that, and this is anecdotally, that at the periphery of very highly fibrotic and encapsulated tumors, you've got an immune cell presence, but that within the tumors, there often tends to be, they often refer to them as sort of immune cold or an immune desert. And so what it indicates, and there's a lot of research in the area about how different elements of that tumor microenvironment might activate receptors on different immune cells in order to alter their migration or invasion, exhaust them, deactivate. So it does appear that in some, but not all, fibrotic tumors, that just the presence of this is acting as almost a bona fide barrier to the infiltration of things like immune cells. It's not all, but it's definitely something that is occurring in some.
Right. Great. Thank you very much.
Perhaps we go to Derek, and then we might move on to the closing Q&A session after this.
Sure, I'll keep this short and sharp. Just quickly, just on the activity you saw on the mean survival advantage for 5505 with Jim in the mouse model, was that done as well in the xenograft model? I know, because I'm asking because I know there's a few mouse models of pancreatic disease around, and they're highly, and there's a lot of things mutated in those models. I'm just curious if you have the same effect in the xenograft model you had.
Yeah, so we, through the APGI and the ATMA cohorts, have access to a large number of patient-derived xenografts, which have all been sequenced. So we have that genetic background. We know what mutations they do or don't have. You're right, the mouse model, highly aggressive, and you see more of that variation within patient-derived xenograft models. And this is still sort of, under intense investigation, what we're seeing is that some of those patient-derived xenografts will have very high levels of expression of the Lysol oxidase family members, and some of them might have much lower. And so what we're actually actively looking into now is, can we, or should we, begin to stratify those patient-derived models in order to really know who's going to benefit from this? Not only do you need or not only would you expect to have a highly fibrotic tumor, but you would also want to see this in the high lux expressing. And so the in vitro data we have suggests that by doing this stratification, it is pointing towards those tumors or cells that would be more responsive. We're still ongoing with some of the PDX models to really answer that question, but it's a great point. You're going to get variation that we want to make sure that we can capture.
Yeah, no, that's great. And just lastly from me, sorry, just looking at that same data, it was curious that 505 wasn't alone. It's interesting you use it in combination, and I understand why, with chemo. However, would you think that using 505 alone as a monotherapy would work so that you allow the infiltration of neutrophils and other immunological cells that can help destroy the cancer? I mean, did you use any 505 by itself just to see, compare, contrast to that thing? And lastly, sorry, given, I think you touched on it, how do you give 505 with gemcitabine? Is it concurrently? Is it sequentially? What's the timing there?
Yeah. So yes, we've done monotherapy. We see no change in survival over vehicle or no treatment alone, as would probably be expected in terms of a model that's highly aggressive, predominantly because 5505 is not seen as an antineoplastic or genotoxic therapy. In answer to the second question, which in terms of the timing, so there were obviously every day the mice were given the PXS-5505, and then twice weekly was the gemcitabine. The 5505 was given 2 days prior to the first dose of gemcitabine, such that we knew that we'd inhibited family members within the body. PXS-5505 given in the mornings, gemcitabine given in the afternoons when given on the same day. So there is a small gap, but the idea was that we were priming, I guess, for 2 days prior to the first dose of gemcitabine, such that we knew, and this is based in discussion with the pharmaxis, we knew we had inhibition of the enzymes prior to the first dose of chemotherapy.
Great.
I
Thank
think
you
it
very
was-
much, Dr. Cox.